So, good evening, friends. On the behalf of Indian Society of Critical Care Medicine, I welcome you all for this second webinar of the series of webinar about the Contain COVID initiative. Today's moderator is Dr. Rajesh Chand Mishra, who is the President-elect of Indian Society of Critical Care Medicine. Today, we have got an honor to have four past presidents here amongst us, Dr. Kapil Zirpe, Dr. Subhal Dikshit, Dr. Dhruv Chaudhary, and Dr. Farad Kapadia. He is joining in maybe in another minute or so. Side by side, we are having honor to have Dr. Gloria Rodriguez and Dr. George Hidalgo, Dr. Prashant Nasa, and Dr. Yash Javeri. So without wasting much time, I request Dr. Mishra to start the proceedings.
Pradeep Rangappa is as well our
Dr. Pradeep Rangappa is also there.
Yeah, he's the vice president as well. So I hope most of the people know George here, even Kapil, as he is the general secretary to World Federation. And Gloria also has been also now a lot of people started knowing in India because she is involved in ISCCM as well as she's the esteemed advisory panel in our critical care communication as a editor. So with that, again, this will be a total extempore discussion. Last time, because this is a continuation of our series, last time we had discussed about vaccination, about the asymptomatic patient and mild disease, and little bit about the knee strain. So continue from there. We wanted to discuss about mild to moderate, and then moderately severe patient. And in third series, we will discuss severe, and fourth will be the critically ill patient. And then subsequently, we can manage. So before I go to our main talk, one of the things which is grappling all over the country is resource utilization. Along with that, we have severe deficiency. I mean, everything has fallen on roof, on floor, that we do not have oxygen, we do not have medicine. No is the only answer we can give, and out of frustration we all have switched off our mobile because we are feeling so helpless that we cannot do anything for any patient. Oxygen supply is not there, no medicine is not there. This crucial point, this webinar become very important. The first thing which I'm going to ask our esteemed panelists, and especially I'll ask because we have panel who has handled first wave. We have a panel which is handling like me, Jirpe, Shubal, Dr. Govil, Pradeep, yes, is there, who is handling second. We are peaking, still we have not peaked up. It will peak, and Dr. Dhruv, we are peaking for that, and Dr. Farhad, if he joins then. And then Gloria and George from Central America, they are handling third peak. So I think we have a vast experience of the people who are handling and how they are handling. And with that thing, my first question goes to George. George, if you can answer. What did you do to manage your resources? Particularly, we are not concerned about whatever you have available. How did you manage your oxygen? Particularly, this is one thing which is worrying. Now, right now, I'm not worried about remdesivir. I'm not even worried about bed. I'm not able to give oxygen to my patient. So how did you handle the oxygen resource utilization, whatever is available? Because we know the demand is 100 times. It's not like 1 or 2 times. Demand is 100 times in my, like if I say 1% of my Indian population need oxygen, that means we are talking about at least 1.35 crores. Means for you, it is 1,200 million people for oxygen in country. So how did you manage? Then I'll come to our esteemed Indian panelists as well. George, to you.
Yes, well, first of all, thank you for having me this morning, and it's and night for you guys. It's a real pleasure, and I know we are living challenged times, and not only you guys. I think so, as Gloria mentioned, it's a situation that is affecting around the world. But back to the question is that it's a very difficult situation to manage, especially in a country like your size. You know, for us, we are a small country, and then basically what we did, and we put a lot of effort, is trying to put all the measures of control, trying to do a continuum care, having the patients managing most of the time, majority of the patients we are managing at home. We are trying to do all the different screening and the different other cell assessment tools. We have lines, I believe, as everybody else, coordinating outreach, telehealth, with the idea to prevent and also, of course, a lot of important media communication to the public to stress on the different measure that the public need to take and put in place to prevent to getting sick. I know it's challenging, but so far for us that has been working. You know, we have right now again the population we can compare, but we don't have at this stage we don't have any patients in our ICUs. Most of the patients are basically being managed at home. I mean, those are the strategies that we implement, and then for a population like us, is probably more easy to apply and to contain.
Okay, good. Kapil, you have been hit hardest with this second wave. Yeah. So how you are managing your oxygen resources?
See, I always say that in Maharashtra we are running with the theme "Break the Chain." I would like to add "Save the Oxygen." Everyone talks about the supply of oxygen, generation of oxygen, get it from the airlifted. Why can't no one talk about the saving the oxygen, the wastage of the oxygen? Why can't every doctor should be trained at the small nursing home and every large nursing home, every 2 hourly, 4 hourly, just see that whether what are his oxygen target? Oxygen target should be 93, 94, not the 96, 98. Cut down your oxygen supply from 10 liter to 8 liter, 8 liter to 2 liter. And as early as possible, come down to the very basic 2 to 3 liter, which is what the basic. So first thing is the save the oxygen should be our tagline for saving, and that's what I'm doing continuously through the media, through the contacts, through my hospital. Second thing, we should cut down the use of the high flows, though it is glorified during the first peak. Try and understand for second peak is worse than the first peak. We need oxygen to be used very carefully. If the high flow is consuming 60 liter, 80 liter, why can't this patient put on the BiPAP and cut down the consumption of the oxygen and precise oxygen supply, and even it will help to reduce the work of breathing. High flow will not reduce the work of breathing to extents like a BiPAP. So second part is cut down the use of the high flow. That is what one of the major advice I will give. And the third thing, just advise your patient to go to the nearby hospital. Don't jump on any name of the particular hospital. Go to the nearby hospital as early as and get the oxygen and get the treatment started. If they get immediately to the nearby hospital, they will be able to manage the further deterioration. Then your oxygen requirement will be limited to the 2 to 3 liter, and we will avoid them going on a ventilator and BiPAP and the further oxygen supply and the load on the oxygen. So we have to work on the root cause analysis. There is no point in running around for the ventilative bed. You will not believe, Rajesh, I am getting every day hundreds of the call for the ventilative bed. Out of that, 90% are only require the oxygen. Even people are not understanding the difference in between the ventilative beds and the oxygen bed. So one need to see it in either in a right way. I will say that to tackle this particular oxygen demand, we should more work on the oxygen wastage. And second thing, what Dhruv always suggests for the home home oxygen facility, but be careful, because our whole Indian system is not geared up for these things. It is not the only oxygen concentrator or supply oxygen at the home you will going to help it. What monitoring, what nursing, even there are a lot of problems with the pulse oximetry. The panic calls are coming because of the faulty pulse oximetry. So it's a multifactorial. It's not the one factor which will going to give us an answer that how we can tackle this oxygen requirement. And the last point, if you go through the statistics, I have gone through the Maharashtra statistics, the Pune statistics in the last week. The first peak, there are 10 to 15% were ICU ventilated patient and 40 to 45% were oxygen requirement. This particular second wave, there is a 50 to 60% is oxygen requirement. Wow. But critical care percentage is dropped down to 6 to 8%. So they require the oxygen, they require the oxygen bed, they require the early admissions and the early management so that they should not jump on the landing with the ICU. So this is where I am looking at this particular crisis, but let's hope it is a worst crisis and we are not properly.
Welcome to you. 1 minute. Excellent point taken, Kapil. And then, in fact, message should go very clear and loud that all the hospital and all medical fraternity should work together to save the oxygen and simultaneously early, appropriate, and right guide. Right is like I will not overemphasize, but I'm guiding almost 150 people daily on video call. Most of the time, the panic call is COVID positive, need admission. We say no, you don't need admission. We have formed a very simple guideline, just temperature and oxygen monitoring, and simple 6-minute walk test. If you do, if everything is fine, just do CBC CRP. If it is fine, you don't need to go. And that is almost, I'm able to, at least from my side, able to stop 20 or 30 admission daily. That's what we are going to help. Dr. Dhruv, I'll come to you last on this issue. Let me ask you a question to other people as well. Pradeep, your thought on very quick, anything you want to add to what Kapil and George just said?
Yeah, thanks, Rajesh. I think Kapil has covered most of the points. But as I was just coming off our government meeting where exactly this discussion happened prior to this meet, where our government was contemplating whether they should set up a big halls like how Mumbai has done, where they could give only oxygen and triaging the patient. But our whole input was it's not only oxygen. Along with oxygen, there needs to be an ongoing comprehensive care. And whatever place we identify, it needs to be very proximate to the hospital where effective triaging and referral, because otherwise you have a place where people are triaged on oxygen, but they may be dying as well because there are a lot of other drugs, other modalities, other comprehensive care that these patients need. So what I would only say is when we are going on a home quarantine, which is extremely good, but they need to be connected to a physician, to a hospital, to a doctor, where they're continuously monitored in some way, in some modality, so that the trends are sort of captured, and then appropriate referral at the right timing is also becomes very pertinent, Rajesh. So that becomes a very valid point.
So if I summarize your thought, there should be a red flag sign where they need to contact the right person.
Yes, they should be connected to a hospital and to a doctor.
Yeah, absolutely. Gloria, you want to add something very quickly about this?
Yes,
because this is something which is very important for us to point out how we can save more and more oxygen.
Well, I can relate because when we had Hurricane Maria in 2017, we ran out of oxygen. So this was approach in a disaster management context, and we divided it between the governmental part, who is in charge of trying to acquire government either from other areas, other countries, and try to advance that. The problem is now this is a global pandemic. So everybody is in need of oxygen. So then you go to your administrative portion, and like one of our colleagues, I think it was Kapil who had mentioned it, that's when you start your rationing and triaging these patients. And not only those with COVID, you also need to attend to those who have non-COVID conditions, and try also to ration the COVID. And that's where you empower the rest of the team. So not only the physicians setting levels, but then you have your respiratory therapist identifying each patient who has oxygen, triage them, see if they need it or not. And if they don't, discontinue it, and empower them that they don't even need a physician order to do that. Because this is a crisis moment, and you want to divert all that oxygen to those in need, and then set your standards. Also, one thing, and you might end up in this point, is when you need to select your patients, and there will be patients who, if they don't have any type of prognosis, you change your goal of care to palliative and divert your resources to those who have a highest chance of survival. Like I said, you have to apply a disaster approach philosophy to your problem of lack of oxygen. One of the things also in terms of government is how do you stop this? And that's where the government also puts measures, either a complete lockdown, so that way you stop that influx of patients coming in and try to get some breathing, because you don't want your hospital system to collapse. That is the role, of the whole thing of getting lockdowns, quarantine, system to collapse.
Good, Gloria. Thanks, Gloria. Dr. Farhad, anything you want to add to this crisis of oxygen?
Not really much to say. I've got two things to say. A couple has said them both, but I just like to highlight them. I think it's many years now I've been saying you don't need to give people oxygen if their saturation is 90 and above. And conscious patients, you really don't need to give them oxygen if it's 86 and above, especially if they are young. So this deeply ingrained reflex of giving oxygen to everyone needs to change. And if you can somehow make a standing order that 86 and above conscious don't give oxygen, 90 and above, no matter what, don't give oxygen, except maybe post CPR or some injured brain. It's easy to say, it's much harder to implement, because for too many years we've been sort of trained into giving oxygen. Similarly, when we ventilate patients, there's a large number of patients we can ventilate on room air. It just has to get into the habit of that. The thing I am not exactly sure I agree with Kapil about is not use HFNO, because HFNO is not the problem. It's how much oxygen you add to the HFNO that's the problem. So you can give HFNO at any flow you want, as long as you limit the oxygen. So, we have low flow HFNO meters and high flow meters, 15 and 60. So as of now, we are saying, please don't use the 60 without clearing it with the consultant. I think the other ones, I don't think it's so bad as, the flow may be high, but the oxygen requirement is not so much. So these are my 2 points.
Great. Dr. Dhruv, final comment, anything you want to add what we have discussed?
Yeah, I think what we have, like I recommended to the government yesterday after having this sort of a turn today is the oxygen audit. That precisely is the area we need to know how much are they using, and you will be surprised the amount of leakages which are there from the central pool, which are there, which could be tuned to the 20%. If you plug that, it takes up. So probably there are two ends. One is the clinical end and second is an administrative end. And when you look at the technical administrative end, we are realizing that in my own institution, nearly 1/3 are having a leaking holes. So that we need to set down. And that's what we need. That itself will save you 20% oxygen, one. Second, which is equally important, is when you are giving oxygenation, that is where the role of oxygen conservative devices come up. But unfortunately, because you are only inhaling it, you breathe in only when you inhale it, actually, not otherwise. Now, somewhere we need to really seriously look at, from the chronic respiratory care to acute respiratory care, can we put a conservating devices? Now, that is where, though I don't know how much it will be, people do talk about Anaconda. Somebody can take up this thing. Can those conservating devices can help us in maintaining? 2, 3, as what Kapil has said it, that we need to tell our colleagues very clearly, low down the standards, like we are putting 93, 94, bring it down to 90, 92%. That will solve. Finally, again, there is a myth we have discussed a lot of time with Nitin also, with Deepak also. If you are having a simple flow meters, you go to the top, you lose up to 40 liters of it. So where you are written 15, you go up. Therefore, it's a comprehensive management which we need to see it, starting from end-to-end solution which is needed to be required to be given. And I agree with Farhad that we need to low down our targets if we have to conserve and tide over this thing. Having said so, we all need to sit down and do a oxygen audit. Our institution need to find. And finally, on high flow nasal systems, you see, you need air actually to deliver, to give the right mix. What I am realizing is that please try to get maximum flow through the air. Then you add oxygenation as a part of which you need it. Suppose I am giving 60 liter flow. So try to keep it oxygen to the minimum, use flow to the higher, so that will also lead to conservation of your oxygen. Not simply saying that we won't use it, but these are the things which you start doing on bedside, and that will help us in conserving oxygenation. Nevertheless, our Government of India, you will be surprised, had been exporting more than 9,000 metric ton each month. Now, obviously, they have stopped it, and industrial production has to be now diverted to our hospital supplies for next 2 weeks or so. I think that is what is required, and probably the states have to learn to helping each other, because the peaks are coming at different times. I think that is very important. Rather than we are all fighting for it, Haryana banning to Delhi, Delhi banning to Haryana, UP. That's the point I'm saying is that should stop. That is creating more panic and challenges.
Yes, you have raised your
few points. At times, if you prone a patient awake proning, you can avoid using oxygen, at least 3-4 levels
point.
you can
Good
bring up.
point. Good
Second point is, if you use BiPAP, you can put nasal prongs into the mask rather than outside the mask. You will require much lesser oxygen. Instead of putting the oxygen on the mask, you put a nasal prong, your oxygen requirement will drastically come down. Third important point is, instead of using C circuits, which many of the anesthetic intensivists use, you can use ambu bags for intubation and for other purposes, so that your oxygen requirement comes down for suctioning or for pre-oxygenation. So these are three important points which I could make. Yeah. Thank you.
Great. Prashant, finally, any point you have to add? I think we have come to very comprehensive, a very comprehensive list how we can save oxygen. If you want to add something to that.
Thank you. I think everyone has added good points. Nothing much to add, except there should be as Dr. Dhruv said, an audit and a central command center for city-based pool of the resources. What I'm looking at, individual hospital is trying to do the best, but what is lacking is clear communication between the different channels and different resources, so that there is a central pooling of resources like what happened in Dubai. We also had a surge almost 4 weeks back, which already preceded our Indian surge like last year. So there was pooling of resources. The people, bed management were part of that pooling of resources. So every day a team was coming from the Dubai Health Authority, which was making sure only an oxygenated bed is utilized by an oxygenated patient, whomsoever it is, whether it's a celebrity or somebody else. Oxygenated bed should be utilized by a patient who needs oxygen. Whether it's your own staff, those should be mobilized to a field hospital or on a home-based system.
Great.
What you have said, Prashant, in Haryana today we have invoked it. 2 days earlier it was in Gurugram. Now we are going to have a live online monitoring of all these things so that we know exactly what is happening. We have started now implementing in Rohtak also from today because of the crisis, and going to be implemented in the whole of the state. So probably there will be a central controlling officer which will know actually the requirement of oxygen which is there, so that we know real time. And this is a process itself required, and we have put the civil servants, HCS and administrative services to coordinate it, because administrative coordination and facilitation becomes much easier there with the help of hospital administrators.
I fully agree with you. So whomsoever, wherever you are, whether it's a rich place or a poor place, ultimately at the time of surge, resource limitation will come. So it's important to pool up the resources and audit up the resources on real time. That's what is required wherever you are based.
Okay, Subal, your last comment on oxygen conservation. Anything you want to add from your?
No, I completely agree with the panel, what you have said, right from Kapil, even when what he has said, Dr. Farhad Kapadia said. So definitely.
Can you just summarize the key point? Can you summarize the key point?
Key points is put the patients in awake prone early. Try and identify the patients who need proper triaging of the patient is very important. Don't give oxygen just for the sake of giving it. Have your targets lower and see that the oxygen targets are maintained to run about 90 to 92, which are even acceptable. That's very important. Do not use HFNO. That's the bottom line.
Here I will correct you. You can use HFNO, but reduce oxygen, give more air. You can give 40% oxygen, 30% oxygen, but you will get good support. So what Dr. Farhad is saying, and I agree with him, that we do not need to cut down the HFNO use, rather than we need to cut down the oxygen use in HFNO, which is wasted. If somebody can and a patient can get help from that.
And along with that, you need to have proper training of your staff, as well as also for your housemen and registrars, about how to cut down on the uses of oxygen. You should equally train them on your rounds. That's also equally important.
Yeah, yes.
One small point, you can use oxygen concentrators, especially in patients who require low flows of oxygen. Those should be utilized, and many of home care patients and many of people have that at their homes also now.
Dr. Farhad, you want to say something?
Why are you all emphasizing 92%? What is the problem with 90% or 88% or 86% in conscious patients? Why are you all hedging your bets when we are in an oxygen crisis?
The reason Farhad is in the Maharashtra task force has given a cutoff of 92.
I know, but you tell them, sorry, you're wrong. I've already actually phoned them. They said we'll try to change it. But the task force is to advise us. If they give us bad advice, it is poor medicine on our part to say. This is
clinically, I accept 90 in my hospital.
Officially say anything above 86 to 90 is fine as long as the patient is conscious. And make it official, our position.
Regardless I agree what you are saying. But in acute respiratory failure minus COPD, you see, it becomes a huge challenge there to convince your whole team, and it creates a lot of bickering and other things. So I think 92% is the reasonable what you are saying. In principle, no difference of opinion from you. Already one has written it that COPD you have to have around 88% or so, which goes much closer to what you are saying. But in the acute settings, acute hypoxemic respiratory, young people, they don't tolerate, they quite often they're agitated.
I'm sorry, Dhruv, you're wrong. Acute hypoxemia is now an acceptable strategy in acute failure.
You see, that is what is happening. It is very easy to talk for that. You need to spend so much of a time.
on there. So
Sir,
around
sir,
90-93%.
Dhruv sir, we need to go to our main topic. We accept, I think somewhere 88 to 90, if patient is comfortable, even 84 we are comfortable, 85 also comfortable. So I think the number should be the basic message which Dr. Farhad wants to give. That number should not be important. Patient condition and comfort should be more important. That's correct, Dr. Farhad? That's what
That I agree fully. That I agree fully.
As long as it's above 85 and the patient is conscious. Those are the two provisos.
Yeah, I agree with you, sir. So that's one strategy we can. So I'm coming to you, Dr. Farhad, for next, because now coming to the main topic. This theme was because we have already taken some part. We are going from mild to moderate patient. So my first question to you, our first point of discussion, why it is clinically important and particularly in this present scenario to divide the patient in mild, moderate, and moderately severe?
I'm personally not too hung up on a clinical division other than for research. I mean, we'll have to make decisions individually. Again, as far as I'm concerned, the way I would look at it, I tend to use criteria used by trials because they tell us what works and what doesn't work. So, I mean, if I'm looking at, say, steroid indication, I would go by the recovery trial regardless of whatever grade you choose to use them. Similarly, if I look at tocilizumab, similar. So I'm not too hung up on whether you call them mild, moderate, severe. As a clinician, you need to know, are they in the right place, ICU or floors, and can they be moved to the right place quickly enough? Do you have the manpower to look after them? And is it appropriate to use whatever therapy is required for their severity of illness? Those are the three questions you have to individualize to a patient. That's how I would look at it.
So how do you individualize it? What criteria you use? What will you use? Any objective criteria or total subjective?
The desaturation and the standard, beside the standard clinical worsening, which we would use in any sick patient, beside that, desaturation out of proportion to clinical condition. That would be that's the only one which is specific to COVID. Because COVID people can desaturate and look pretty good, and you can be sort of, suddenly they will be 60 and 50%, which is very, very unusual in other illnesses.
And Glory, question to you. How important it is for us to know and what criteria to divide the patient in different categories, particularly in doing triaging, because this is also related to resource utilization properly.
It's very important, and Dr. Farhad, I agree that putting patients on different things, mild, moderate, severe, there's a gray area, and that's where your clinical judgment is very important. We are still clinicians in clinical judgment. But when you do these types of classifications, it helps people in the front line. And we have to remember, us as intensivists, we are in the higher part of the critically ill, but we need to give tools to people in the front line to be able to triage, diagnose, and manage these patients appropriately. If you have somebody with mild disease, that person does not need to be hospitalized. That person can be managed at home with monitoring, and that helps also institutions, administrators to establish protocols and surveillance, protocols. If somebody has moderate disease and that person, has infiltrate, saturations over 90, there's a sex rate, that is somebody that the clinician might decide, does this patient needs to be admitted or can I monitor that person somewhere else? And, the severe patients, those will be hospitalized and the critically ill will be hospitalized. Those things are also not only for research purposes, but they also protect your hospital system from collapsing. And it also helps in the guidance of your scarce resources, not only oxygen, but remdesivir, other medications that you want to do. So I think even though we can't have, a square definition and very rigid definition, these things help people in the front line to make clinical decisions.
Okay, and George, so what did you do to differentiate the patient in different category in your country? How did you define that this patient is mild, stay at home, this is moderate, can be monitored in ward, this patient is severe or critical, has to go to ICU, and then if critical, definitely he needs to go to even SDO and ICU. That's what. So what 1 or 2 points, very quickly, if you have to make something and tell our audience that, okay, you monitor this thing. If this is this, probably your patient is mild category, or this is there is moderate, and this is there is in severe, and accordingly to raise the red flag sign.
Yes, well, that's an important question. And again, for allocation of resources, it's important for us to have this category of patients. No, I mean that the asymptomatic of a mild cases, we essentially say that it's a patient that have an peripheral oxygen saturation more than 94% at room air, no radiographic evidence of pneumonia. And it's important because we know that these patients definitely can be managed at home. Then we pass to the second category, where we have a moderate disease, and we need to have in consideration high risk patients that definitely they will have a poor outcome. And those patients are patients more than 60 years old, with probably some additional risk factors and with some signs of pneumonia. Those patients probably they will need to go to symptomatic treatment with supporting measures. Also, if it's a possibility in areas that you have resources, probably they are also candidates for trial enrollment. If it's the case, if it's an opportunity, and also we can also have consider some of the agents that are in trial for investigational agents. And then we pass to the third category, where we have a severe patient when we know that we have hypoxemia, saturation less than 94%, but also we introduce the concept of happy hypoxemia, where we, as you mentioned, we can manage less than 90% oxygen saturation, knowing that these patients don't have any signs of respiratory distress, and that we can also decide what type of resources this patient probably definitely go to a different oxygen support in different levels. That depends on what is the clinical scenario, and then we decide. And then also these patients go to different type of treatments, either remdesivir, dexamethasone, or tocilizumab. I mean, that's the importance for us to categorize the patient for allocation of resources.
Okay, thank you, George. Yes.
One quick point. What we did in our state is they categorize bed into 3 levels: L1, L2, L3. L1 is without oxygen, L2 is with oxygen, and L3 is like a critical care bed. Accordingly, mild, moderate, severe patients land up there.
So oxygen monitoring is one criteria to decide where simplest criteria is oxygen monitoring, so where patient will go. I mean, if I have to decide, if I have to categorize and tell my audience today that if this oxygen is there, you can stay at home. If this oxygen is there, you need to take supervision. If this oxygen is there, you need to go to ward or high dependency. And if this oxygen is there in critical, if I have to decide just based on oxygen level, can we have some?
Rajesh, like look at the data which has come up from the West. So we need to see, especially people who are dark colored, there is a probability of having false oxygen values. And similarly, we need to be very careful when we are using oximeter. If the batteries are going up, they can get very erratic values. Therefore, it is not simply monitoring, but clearly teaching people how to do, what to look, and we need now to look at it. Is there any difference data in the dark people? Because when they started looking at the mortality in the black people, why it is high, so it was blamed to the monitoring of pulse oximetry. I think what we are realizing is that absolute values are fine, but people need to be told very clearly, and yes, rest everything what you're saying holds true. But that point needs a lot of emphasis now.
Pradeep, what did you do in your state? Because you have been doing a lot in making your state policies.
Yeah, I think I resonate with what others have said, Rajesh. I think optimizing your oxygenation as a as a criteria to triage your patients is extremely important. One thing is to optimize resources, and second most important thing is to realize to improve the outcomes as well, Rajesh. Because I'm sure all the esteemed panelists would agree that steroids are being given indiscriminately for people who are not on oxygen, and remdesivir also is being given for anyone and everyone. And that's why you see the shortage of these valuable resources. And clearly, if you see all the trials of remdesivir or steroids, very clearly it is shown that remdesivir has been used only in patients who are on oxygen with an ordinance scale of 5 and above. Even the benefit has been found in this group. So to optimize the resources is extremely valuable that we take this as a very important criteria. and to improve outcomes also, because using steroids in these patients who are not on oxygen may influence their outcome in having more mortality. And even not using remdesivir in just looking at the CT and having some ground glass opacities and using remdesivir in these patients may not be justified. So that's why we are seeing shortage of these agents. So I think oxygen cutoff would be a good way to at least rationalize in the tertiary care. The rest of them could be triad. Either they go
So
to see in our state.
What is your cutoff? Pradeep, what is your cutoff? Very quickly for audience.
Right now,
they want to listen the number. Keeping everything aside, they want to hear a number.
Yes. Rajat, I'm coming. Right now, our protocol says 93, but we can argue on that. We can come down on that to triage it better. But 93 is the current cutoff in our state.
So 93 for hospital, 93 for ICU.
So we have divided into 3 categories. We have called as CCC, which is called COVID care centers, where any stable patients will go. And then we have designated COVID health centers, where even patients who have these GG opacities, but who are maintaining reasonable oxygen, who are symptomatic, they go.
So,
and COVID hospitals is where people go with oxygen.
Use number. Reasonable is not a good word.
Yeah.
Use number.
So DCH is the place where they go when they are needing oxygen, which are designated COVID hospitals. So this is the place where they go when they are needing supplemental oxygen.
So suppose you get a panic call from a relative. He says, my patient is there, COVID is positive, CT score, which everybody is doing nowadays. Even if you say I don't do, the moment COVID positive, first thing they rush to radiology and do CT scan. My CT correct score is 10 and my patient is feeling breathless. You say oxygen, it is maintaining 96%. What will be your advice?
So obviously, if they are saturating well, I wouldn't give steroid, definitely.
No.
And remdesivir also, I wouldn't give unless.
Suppose I give you a call. What will be your advice? Be precise. What will be your advice? What will you tell the patient?
So my advice is, first thing is compassion. Yeah. So my advice would be compassionate reassurance to them, not to panicky, because panicky would be causing his symptoms, and then give symptomatic treatment. That's it, Rajesh. And although our state protocol has ivermectin and all this favipiravir, but I do not recommend them.
I will come to that. Kapil, you want to add something to this, because very important thing, very quickly.
You're talking about the triaging.
No. Right? I'm talking about the how do we divide the patient in mild, moderate, severe? What criteria I use, and what is the criteria? Like, when will you ask the patient to stay at home? When you will ask to come to the hospital and go in oxygen room?
Rajesh, this question should not be asked because it is well established since last 1 year.
But still, Kapil, still people do not know. Still people do not know and follow.
Simple. Asymptomatic patient, home quarantine. Mild patients with the saturation more than 93, home quarantine. Mild patients with the high risk comorbidities, admit in a ward facility with a non-oxygen facility, the saturation more than 90%. Moderate to severe in a step-down unit, HDU and ICU as per the requirement. What I observe nowadays, because if you do not do the triaging in an emergency system in a proper way, you will landed with the bouncing all these general ward and ward who having the low oxygen into the ICUs and HDUs, and that will be the excess load on your existing system. So you have to put a very sensible guy in a casualty, because oxygen saturation should not be the one criteria. If suppose somebody comes with a decay, he doesn't require the oxygen, but he will go to the HDU or ICU. Somebody comes with the stroke, somebody comes with the organ failure criteria, what we are using in a critical care, the patient's clinical condition on admission, then oxygen requirement and comorbidities with the age. So it's like a comprehensive. It is not the one parameters will decide oxygen go left or no oxygen go right. This is not the way we should do it. I feel every hospital, every institute should have the good, the good experience fellow should be emergency medical system to avoid a load into the unnecessary on the wards and this thing. So that is how we manage in our institute. So the demarcation is clear cut. Only we need to segregate in a properly in our emergency medical system, but not only the oxygen criteria. There are other organ failures or other organ systems also decide the admissions in a critical care area.
Okay, Prashant, any quick addition to that what Kapil and others have said?
Dr. Mishra, I think it's a very important point. You know, when we say mild, moderate, severe, it's primarily talking about respiratory disease. We are not including the other criteria of admissions.
That's why I wanted to make it very simple thing.
Another important point is, you know, the most of the guidelines, World Health Organization or CDC or our own local guideline in the Ministry of Health, it says hospitalized without oxygen, hospitalized with oxygen. So treatment is decided by this criteria. Non-hospitalized, there is no role of any other antivirals other than adjuvant treatment for symptomatic treatment. If it's a hospitalized without oxygen, then only a treatment or consideration of a antiviral is considered, which in our guideline is purely favipiravir till patient comes on oxygen.
Okay. Subal, you want to summarize finally what we said something?
I completely agree what Kapil has said. It is very easy to distinguish between mild, moderate and severe, and definitely my observations is that in Indian practices, favipiravir is not that effective as compared to the other population. And definitely mild patients or even those patients with mild asymptomatic patients should be at home. And definitely those with certain amount of risk factors should be without need for oxygen should be kept in the ward facilities, or those with hypoxia or those with risk factors, they can be kept into an intensive care unit or oblique HDU, where you have got facilities for oxygenation and proper trained nurses. So that's what is the key. Using the drugs as far as for home quarantine, usually we are just giving vitamin C or paracetamol for reducing the fever. And especially if there is cough, we use azithromycin in few of the patients. But my observation is favipiravir has not been as effective into the second wave as compared to the first wave, and now we are not using favipiravir currently for any of the home quarantine patients. It's a symptomatic therapy, and we just request them to report to the doctor the pulse, saturation, and the 6-minute walk test, which is very important.
So, Glory, coming to you, if you have a patient who is of moderate category, and you decide to keep him in hospital for observation for some reason, maybe his oxygen is 92, he has X-ray shadow, CT scan or X-ray shadow, but he doesn't need oxygen as you decided. So what will be your advice in the ward? What will be your protocol in the ward, and what medicine you are going to give to this patient who has moderate category, who has fever, some shadow, but doesn't need oxygen? According to, if we lower our threshold, he's not tachypneic, he's not tachycardic, maintaining a saturation of around 92% shuttle, but he becomes breathless when he goes to ward for his routine activity. He's going to toilet, he becomes breathless. So what will be your activity? How will you manage this category of pool of the patient?
So moderate without oxygen requirement, is that what you're talking about?
Yeah, because we have lowered now our threshold. If I follow Dr. Farhad, 85%, 86%, because patient is comfortable. If I follow myself, 90%. So 92% is the oxygen saturation, doesn't need oxygen, but he becomes symptomatic. He has done CT scan. His primary physician in India, I don't know what happens in your country, but if he's going to primary physician, he will come the list of at least 8 to 10 drugs, favipiravir, vitamin C, vitamin D3, then Dolo, azithromycin, doxycycline, ivermectin, I don't know, maybe anything I left, I don't know. So many medicine will be written there. So what will you?
Well, the one thing is hospitalizing somebody with moderate disease without oxygen requirements, if it's only because of the respiratory thing, you're denying this person the opportunity to receive monoclonal antibodies, which are indicated for people with high risk, mild to moderate disease without oxygen requirements. So that is the one thing that we need to also pay attention. If we are doing more harm to a patient when they get an admission that is not indicated, or medication that is not indicated. We have recovery trial, Act 2 trial, and the only 2 drugs that have been demonstrated that are indicated in oxygen requirements are steroids and remdesivir. And as I think everybody will agree, timing is of the essence with these patients. If you give it too early, you're doing harm. If you give it too late, you're doing harm. So timing is very important. And clinical judgment, never forget. I mean, we are clinicians, and I think that is key to the success of the individual patient, the clinical judgment. So if you have this person that has been hospitalized and doesn't have any oxygen requirements because of the saturation, you might inquire a little bit deeper, do ABGs, see if that person is truly hypoxemic, not because of the saturation, but because of the PaO2, and try to explore other conditions. But given ivermectin, antioxidants, antiretrovirals, those things have not been proven in trials that have been effective in this condition. And we do practice evidence-based medicine. We are scientists, we don't practice propaganda-based medicine or eminence-based medicine. We practice evidence-based medicine.
Great. Dr. Farhad, same question to you.
I'm very uncomfortable disagreeing with the previous speaker. Of course, we practice evidence-based medicine. My reading of the evidence is that there are only 2 studies which have shown a mortality benefit, and both are recovery studies, recovery steroid and recovery tocilizumab. Unfortunately, tocilizumab is only published in a preprint format, so I'm waiting for the final one. Remdesivir, I got to say the trials are unimpressive. The first one showed the primary outcomes. The first one showed some decrease in hospital stay, but no other major changes. The second, large solidarity, showed that it made no difference to any outcome, and WHO actually withdrew it. And yet, based on some subgroup pre-hoc, post-hoc analysis, it seems to have got itself entrenched in. So I am not as confident as our previous speaker that the evidence base of remdesivir is as strong as it's made out to be. And in my view, it's a national tragedy what is happening with remdesivir. People are running pillar to post. There's a black market. Politicians are in the game. They're in the game for a drug which does little or nothing. And there's a stunning silence on the absence of tocilizumab. I mean, of course, I would like the recovery trial to be published. But the pre-published format it's pretty much as effective as steroids. It has a mortality benefit. There's a clear protocol, clear indications, clear everything. So I think we should be using steroids on everyone. Tocilizumab is not available, so that's the end of that story. But if it's there, we should use it as per the recovery trial till such time as it's published. And I don't have strong feelings about remdesivir. There's so much momentum that it's almost impossible not to give it. But I think the momentum has far overtaken the evidence. The evidence is, as far as I can read, is a subgroup post-hoc analysis. And that, in my view, is not the best way to form a national or international policy.
But the question was, what will you do with that patient? Suppose that patient is admitted under you, he didn't need oxygen, he becomes breathless. Only symptom is sometimes become breathless, he has fever, but his oxygen saturation is 92%. So moderate category patient without oxygen, what will be your prescription?
Pretty much standard observation and intensive care, and nothing specific to COVID.
Okay. So the message which I want to give through you and through all of you, that if a patient doesn't need oxygen, except paracetamol and some symptomatic treatment and close monitoring, it doesn't need anything else. Everybody agreed with that? Anybody has different view on this?
So what I would say, I would frame it, there is no difference in the management of a COVID and non-COVID patient.
Is right. But having said so...
Dr. Dhruv, Farhad has not completed. Let him complete, sir. Dr. Dhruv, 1 minute.
I completely agree with what you're saying. The management of a non-COVID patient, which is 92%, exactly the same thing we should do for a COVID patient. There's nothing specific about COVID which needs different intensive care. Obviously, we have to worry about rapid desaturation, but that's pretty much the only difference from any other patient with any other form of infection, be it malaria or sepsis or pneumonia or pancreatitis. Our approach should not be different for the patient to describe.
Yeah, what are you saying, sir? Dr. Dhruv, sir, you're saying something.
You see, what Farhad said in terms of evidence, I do agree with it, but look at it. His viewpoint is that, let's say 86%, I respect that. But if we go by the international guidelines, everywhere it is there has to be some method in madness. So probably 94%, I will continue to take it as a sacrosanct. I completely disagree with him, though on theoretical basis in terms of conservation of oxygen may be right. Because very simple thing is, whether you take WHO, you take UK, you take CDC, everywhere the guidelines have been there. You don't do 94, something goes wrong tomorrow, then you will be running around in the courts, one. Secondly, in these cases, when we are talking in terms of what Gloria has talked about, I now know it that 4 people within the north, Deepak knows it also, who have now been given the Regeneron's monoclonal antibody. But now with the new variants coming up, we need to see the effectiveness of these particular things in the coming time. But I personally, by the personal accounts, I know 4 people have been given monoclonal antibody within our country. That is one. Second. Third, I will just call again here. My dog just started.
Okay. And Dr. George, you are saying something. You wanted to add something. You have raised your hand.
Yes. Well, essentially, just to be very punctual. No, I know we are running out of time. let's put it that way, symptomatic patients, more than 94% is the patient is the treatment is on outpatient basis. Moderate disease, high risk patient with more 94% of oxygen, but no major changes of distress. This patient also is symptomatic treatment. But if we have a patient with a severe disease, hypoxemia, less than 94%, with signs of distress, then this patient needs to be hospitalized, and then we already need to decide what type of oxygen support we are giving, and also what type of additional treatment we are going to use, either remdesivir, dexamethasone, that are the more accepted one, and then also, depending on the resources, we can use other medication, but more or less this is to put it in the three categories that we know.
So in general, consensus is going towards cutoff of 94%, not something else. Yes, you are saying something? Yes.
Yeah. All patients with COVID who have been admitted, they have to risk stratified for risk of pulmonary embolism and DVT. They're highly prothrombotic. So adding enoxaparin or heparin preemptively as for any critically ill patient is must.
No. Yes, you have lost the track. We were just talking about moderate case without sign of hypoxia. He doesn't need oxygen.
All patients, regardless of severity, if they have been admitted, so we have to risk stratify as for any other critically ill patient.
So you say that if when they are admitted, if they don't need even oxygen, think for using anticoagulant, if like D-dimer is high or something like that.
Not D-dimer, as we risk stratify a general patient in our ICU, the same approach.
Okay.
Yeah, not D-dimer based.
Okay.
Yeah.
Dr. Dhruv, you are saying something and got
basic problem where you are facing is the people who have got a high risk. Person who is obese, person has a diabetic, person is respiratory disease. What to do there? Now that's what we need to look at it. And persons who are elderly now. If you look at the trial data, we have all thrown away the convalescent plasma because of the trials which have come up, which have not shown any promise. But if you start looking at the elderly trial which was published in NAGM, depending upon the robustness of the quality and the quantity of the quantity of the antibodies people are trying to use in elderly. Suppose there is a patient who have other risk factors. Now, again, this is a very controversial area. People can be divided, but when these trials were done, nobody knew what are the neutralizing antibodies, what are the levels which were there. So probably even for the convalescent plasma, we now to relook at it, and we probably may have to redesign a trial to see what are the neutralizing antibodies, because within the first 10 days or so, we need to look that part also, which we have actually completely put under the, we were thrown away. So I think it's a very dynamic things which are there. What looks to be true today may not be true tomorrow. Therefore, when we are seeing with the newer evidences, I think time is there to look at it. Similarly, in moderate, we have no hesitation in using dexamethasone. We are looking at 0.1 to 0.2 mg per kg, depending upon it.
Again, remember Dr. Dhruv, Dr. Dhruv, one point. Who is moderate for you?
For me, a moderate is a person whose saturation is less than 94% and the respiratory rate is up to 28 to 20, less than 30. That is what we look at it. Anybody up to 20, you take normal. So respiratory rate for me is very important along with it. We are simply putting and concentrating it. Person may be having a saturation. Youngsters, you are finding a problem because they are hyperventilating. They have a more reserve, so they desaturate late. And if you do not look at respiratory rate, we are additionally adding two more things to stratifying it. One is a single breath count. If you see at the BOG test what the British Thoracic Society is calling it up, you calculate, which we have been doing all the way, 1 to 30, how much time are you taking up when you don't have a clinical data? And we are also, along with it, taking it up the desaturation or 6-minute walk test. If person desaturates by 3%, for me, this is the risk stratification I'm looking at it. So then we are following up emergency warning scoring systems. If the 2 points go up from the mild towards it, that's what we are doing in home isolation to pick up cases early. Okay. Therefore, when you are doing this stratification, simply basing on respiratory is not appropriate. You need to look at other things of respiratory reserve. And third, as somebody talked about, obviously, if somebody has the risk factors, gradually we will put it up a stage early and in the elderly people. And therefore, it is a comprehensive thing rather than simply one thing which is there. But yes, dominant brunt is set by the respiratory system. Therefore, we are all going with the SpO2.
Just coming to the from that, Prashant, you are there. Prashant, same case, even on 94%, but patient is little tachypnic, respiratory rate around 30, SpO2 maintained around 94, 95. What will you do to ascertain that this patient may be going from moderate to severe disease or may need oxygen? Is there anything you want to do? Any test, any clinical examination, something like that?
So the clinical examination is basically continuous observation. So if patient saturation at the bed is above 94%, we need to just continue monitoring him as Dr.
You will not address tachypnea?
I will not address tachypnea. That's a natural compensation. For severe disease, there should be a saturation which should be less than 94%, along with respiratory rate of above 30%, above 30 per minute. So if both the criteria are there, that's the point I would like to add a steroid.
Suppose rate is 35, 40.
I would like to know the cause of the high respiratory rate. If it's alone tachypnea without any...
patient has come with CT scan. CT scan is showing that CT scan is more than 60% lungs are involved.
So then CT is already showing a severe disease.
Yeah.
Okay, so that's a point where...
No, but CT scan is not a criteria to decide disease, critical disease. CT scan is just one information. So would you like to do any test? Like, do you place anywhere in this test patients who are having moderate patient without oxygen, needs oxygen, and moderate going to severe? Do you find any clinical test, maybe 6-minute walk test or something like that, which can help you in guiding that this patient may need early intervention? Because key lies in early intervention. If you delay, if this patient goes in cytokine storm right from moderate directly, you end up losing this patient, and it's a fraction of a second. So it's something you can put on red flag that if this happens, you do this, alarm us, something like that.
That's the right point. The 6-minute walk test we do use to start up a treatment of remdesivir. If I come specific to a clinical criteria, which I use for starting antiviral for this patient, 6-minute walk test. But for otherwise continue monitoring to add such oxygen, no, definitely. So this patient doesn't need oxygen at present, which is above 94% on rest. But if we decompensate on 6-minute walk test, so that's the time we consider adding antiviral.
So Kapil, coming to you, many times you keep patients for observation, they are moderate, doing well, they go for a loo and then suddenly come to room and they become breathless, saturation drops. Sometimes they land up in your ICU, sometimes they settle. What is the red flag? What is that one red flag or two red flag sign you keep for the patient? They are at home or maybe in hospital, in room or isolation, not needing anything. But when you will ask patient, relative, doctor to be careful in that patient, what will be your criteria to tell? Yeah, if something happen like this, you have to alarm me, alert me, because this patient doesn't need only observation, some treatment. Maybe starting early antiviral, maybe starting steroid also, someplace. So because if you intervene early, you have done good and you can save a lot of money to the patient. But same thing get delayed and patient lands up in ICU, with particularly cytokine storm, then you are in problem. So this question, one by one to go to all, but I want to take you initiative from here. Because this is a common problem everybody faces, and this is what the apprehension is. Whatever prescription you are seeing today, early oxygen, lot of medication, apprehension is that my patient is mild, moderate, he should not go to severe. We all intend to prevent severe, but probably do not know how to prevent this patient progression from moderate to severe. So what can be done and how do you do that in your practice? In a nutshell, how do you prevent the progression of a patient from moderate to severe?
See, first thing at the home isolation, we need to just follow with the 6-minute walk test and the oxygen saturation target less than 92. If they are anytime coming across such readings, come to the hospital. That is the first thing need to advise to avoid the late admission. Second thing, when we are talking about the wards, what you mentioned is very important. The most of the patient deteriorate when they go to the washroom. So during the morning round, it's become a habit of myself looking at the monitor, looking at the parameter. I ask them the very simple 3 questions. How many times you yesterday went to the bathroom? How much time you spent in the washroom? And what was your oxygen saturation when you came back to this thing? Whether have you felt breathless or you are able to walk to the washroom? So in general ward, there are the few washrooms for the more number of the patients. So we have to be very careful in the wards and the semi-private about this phenomena. And second thing, if suppose there is a debilitated patient who is not able to go to the washroom with the support, I prefer to do the early Foley's catheter. Many will criticize, but let me tell you, if you do the Foley's catheter early in these patients or urine drop for 3 to 4 days, their oxygen requirement will come down and then you can remove before they catch up the second infection. And in ward, we are not much worried about this thing. So what you said is right. The ward patients and the semi-private patients, those going after the washroom phenomena is very common. We need to tackle it on an aggressive basis to avoid the sudden surge to your ICUs. Third criteria, when you are managing the patient in a HDU, that is next to the ICU, I not agree with it. I will distinctly disagree with the Prashant. I follow the respiratory rate as one of the major criteria. If the patient is tachypneic, respiratory is more than 30, it is for me the work of breathing. I'm not much bothered along with the oxygen saturation. I'm much bothered about the work of breathing. If such patients, you give them the non-invasive ventilation or high flow to reduce their work of breathing, their oxygen requirement will come down. So respiratory rate will remain one of the main criteria to decide whether he requires to shift to the ICU for the close monitoring and this thing. And the fourth parameters, their patient is already on the high flow and going or already on the NIV and they need the invasive ventilation. Believe I am not having any phobia about the invasive ventilation. I have used this invasive ventilation in the early phase during the first week very successfully. I dropped down for my mortality from 90% to 68%. And I think that is a significant, one of the major criteria I have decided for the invasive ventilation is the respiratory rate. In spite of the NIV, what misguided us during all these COVID patients, they are eating, talking, speaking, hypoxia with NIV 80%, 100% for 5 days, 10 days, which is the criteria to continue the NIV for 8 days and 10 days with the effort to more than 60%, with the respiratory rate more than 30%. And if you intubate them delayed, you landed with the more mortality on invasive ventilation and the more sepsis event. So when I retrospectively look at my data, those patients who are early invasive intubated from the NIV, they have a 70% survival mortality as compared to the 90 plus on those who are late after the 72 hours or 96 hours. So I'm saying don't get away from the invasive. I am not saying that each and every patient should be intubated immediately. It's a clinical judgment. You have to give a time to that patient during the round, take a clinical call, but along with your respiratory rate, along with your organ failure, along with your Apache scores, whether they are dropping and organ systems failures associated with that. So this is how the whole concept is avoiding the mortality, avoiding the delayed thing. In critical care, we have taught from the day one, don't delay your intervention, don't delay your therapies, don't delay your offering to the patient. But again, it has to be leave it to the treating team and the treating physician and the backup supporting staff as well as the trained staff. That is what I am doing in my practice quite regularly. Thank you.
Thank you, Dr. Farhad. How will you progress? How will you prevent? Because Dhruv sir, 1 minute, please. Let me ask finally. I will come to you. So please, sir. Dr. Farhad, a very specific question, because this is impertinent to saving a lot of money to the patient. If you can really have some good strategy in an institute to prevent the progression of moderate to severe disease with quick early pickup of the patient who are at risk of becoming severe, you can save a lot of mortality and mortality. And most of the people do not know or are not able to differentiate, and that's why these huge crises is looming up. So what you do in your practice?
I am unaware of any specific COVID therapy which prevents progression of disease from mild to moderate or moderate to severe.
Absolutely.
So all the standard criteria of intensive care which we have done for any other patient is the same we should be doing for this. I'm going to keep stressing this again and again. Everything we do to our standard intensive care patients, whether it's their hydration, whether it's their sugar control, whether it's their DVT prophylaxis, is what we should do. And all the things which worry us about the standard patient, whether it's LVF or whether, is exactly the same things we should be doing. As of now, I am not aware of any intervention which it mild prevents to moderate and which moderate prevents to severe. Over the time, new trials may show that. So I'm not greatly hung up on the cytokine storm. All patients who are septic do have some cytokines, and all patient cytokines go up and they come down. And so the first thing is, other than standard intensive care, I have nothing much to add for prevention of progression of illness. And I am not convinced that any therapy in the last year has prevented mild to moderate or moderate to severe. So therefore, by using it easy, we can actually cut off that severity. I am not convinced about that.
Okay, thank you, sir. Pradeep, very quick point, because this is something you can add. Do you do anything except monitoring, close monitoring, what everybody is mentioning? Anything else?
Yeah, I do close monitoring, but nowadays I'm using ROX index to all these patients because respiratory rate is very important component in this ROX index. And we are seeing patients are improving. Generally, the ROX index tends to improve, but in patients where ROX index deteriorates, invariably they go on to intubation. So I'm using this tool, and we have included it in our state protocol as well, Rajesh. So it's a valuable tool, I feel.
Good, good. Yes, you want to say something on that?
No, nothing to add. Probably there has been no intervention for any disease, leave apart COVID, which can stop progression of the disease. So there will be nothing.
How can you pick it early? How can you? It's not a question of therapy. It's a question
Yeah,
of how can you pick it early, your progression of moderate to severe disease?
I think we will follow the regular interventions which we follow as for any other critical ill patient, nothing specific.
Glory, you want to add something to that? Anything you do is specific? Subal?
Close monitoring of the patients, that's all. There is no medicine which is going to avoid the progression.
Dr. Dhruv?
Prevent progression.
I have a very strong difference of opinion with all of you. Again, I'm provoking. I've learned something from Farhad. Reason is the one which is progressing, like you're talking from mild to moderate and other things. I think we need to take a comprehensive, we all simply going by the book and we find difficult to put our neck out. The drug which is making the whole difference actually are the steroids. If you really look at it, whether we like or dislike it, early intervention, remdesivir probably may not, because as Prahad has said, Act 1 and Act 2 trials have been trying to show, and that's what Paul Sachs talked about discussing in NAGM and other things, that whatever the role of antivirals probably is in the first week, and that can help it out, or the monoclonal antibodies which you can use in a high-risk patients, which can actually prevent shifting it from mild to moderate. But having said so, the one which is actually taking care of is the steroids. How early, quickly you are using, because we are all blinded by the recovery trial, which is there, data is there, evidence is there. But we are having a significant group of people we have discussed so many times on the various groups, which patient continue to show inflammatory markers going up, clinically deterioration setting up. If you use these patients steroids early, that is one very big savior. And there could be a difference of opinion, and time has come that we keep on looking at it, the data which is a year old, to make our own studies and see and prove or disprove it. But if somebody says nothing is happening, I don't agree with it. You look at it, early use of corticoid, agree, do not agree with it. What Gloria said, crux is timing. Therefore, if we simply leave it on an oxygen or something, that let them go to it, I don't agree with that one. Second point, which is as important under this is, everybody talk, what has been taught to me as a respiratory physician. Whenever you have a cardiac failure, your cardiac output reduces, stroke volume goes down, the heart rate goes up. You come to the respiratory system, your tidal volumes goes down, or the pump is not able to minute ventilation is maintained by the respiratory rate. Therefore, it is very important for us to look at the respiratory rate. This is the most comprehensive sign in critical care and most of the respiratory patients. Thirdly, if I have to do work of breathing, I not only look at respiratory rate, but I also look at accessory muscles of working or not. So I look at clitomastoids, I look at intercostal recessions, which are as important. So if somebody has a nasal flaring, it means you are having a problem. And I agree with everybody, and I agree with Farhad. Good critical care is the key. Whatever you may do, that nobody can. And finally, the last thing which I need to add up to this place is, when you are seeing the data, it all depends upon your team. If your team is good, if I have got given the residents from ophthalmology, pathology, or from orthopedics, I will be shuttering down, intubating it. But if I have got a good DNB, DM fellows which are working with me, I have no hesitation. So I think a lot of it depends upon the logistics at the place you are working, but no second opinion about the good quality critical care.
Good, sir. Glory, coming to you, last question, because now we want to wrap up. $1 million question. When do you give remdesivir and steroid in your patient? What is the starting trigger for you?
The trigger is oxygen requirements before you go to high flow and invasive ventilation. So once you have moderate disease with increasing oxygen requirements, that's your timing for remdesivir. If the patient already goes into non-invasive or invasive mechanical ventilation, that's too late. And that's the articles that Dr. Fahad was referring to in terms of the subgroup analysis. That's where it was found first, and it's 5 days. If the patient is already in the ICU intubated, that's not the time to start remdesivir. You're not going to see a mortality benefit, and which was not seen on the subgroup analysis. What you were, you're not going to see the reduction in length of stay and deterioration.
So, Kapil, would you like to give remdesivir in a patient who is severely ill with and need ventilator? Will you give remdesivir or not?
No.
Great. How many of you will not give remdesivir in a patient who is intubated and on ventilator? Dr. Parad, I'll come to you. Who will not give? Raise hand. Pradeep, you will give?
Rajesh, I think the role for remdesivir is the window is very key thing, because all the studies, if you interpret however you decide, within 10 days is what it is shown. But within 10 days, that study by Goldman has shown that in intubated and mechanically ventilated, it had a mortality benefit when you give remdesivir for 10 days. So going by that, if my window is within 10 days and I have intubated this patient, I would give it, Rajesh. Within 10 days, that's the key. Within 10 days is deteriorated, I would give it.
Dr. George, when will you give steroid and remdesivir in your patient? And when will you not give remdesivir and steroid in your patient? You are muted. Dr. George, you are muted.
Sorry, I think so. In terms of the remdesivir was very clear. If a patient is not intubated, then we put on the remdesivir for 5 days, and we can extend the remdesivir up to 10 days if there are no improvement in patients, even if they are in ECMO. It's a decision that we need to make, even that despite that it's clear that most of the times, or it's clear that these patients or remdesivir is for patients that are not intubated, but we can extend it up to 10 days if we see that there are no improvement. And then, of course, we combine with dexamethasone, 6 milligrams up to 10 days alone in patients with severe disease.
Okay. Subal, when will you give steroid and remdesivir, and when will you not? Very clear. And then I want to go last question and go.
Yeah, steroids are used early at the onset of hypoxia also, not in mild patients or those who are not hypoxic, but at the onset of hypoxia, we use steroids. And even at the onset of hypoxia, yes, remdesivir, if initiated early in time, it is beneficial, but not into those patients who are terminally ill, those who are beyond 8 days, and those who are intubated and ventilated.
Prashant.
I add to Dr. Shubal, we keep it 10 days. Yes, if patient is out of that 10 days window, we definitely do not add remdesivir. Steroid only when patient is on oxygen. For us, the starting of oxygen is above 90%. So if patient is on oxygen, to keep saturation above 92, we add oxygen. That's the first thing. Along with that, remdesivir, if it is within that 10 days window.
Okay. Yes, your final comment.
Yeah, if saturation level is less than 94, I will start steroids. If patient is hypoxic, either on HFNC or oxygen, or even BiPAP, and within a span of 5 to 10 days, I will give remdesivir.
How many days?
Not more than 10 days.
Okay. Dr. Dhruv, I'll come to you because I want your conclusive remark and then we want to close. Dr. Farhad, when do you use tocilizumab? Use or not? And when will you go?
After recovery came out, I started following their criteria. Their criteria is it's a little difficult paper to actually understand, because in the method section, there's one thing, and in the result discussion, there's another thing. So when the final paper comes out, I may be able to give you a better answer. But at the end of the day, what they said is the CRP is more than 85 and the person requires oxygen. Then across all spectrums, there was a decrease in mortality. The dose was 400 milligrams for those less than 65, 600 milligrams for 65 to 90, and 800 milligrams for those above 90. If there was no if there was a deterioration in the first way, despite that, a second dose of the same could be given. So that's that. I basically follow the recovery protocol. till such time as tocilizumab was available, and after that it's not available, and that's the end of the story.
Glory, when you use Tosi? This last question to you.
Same protocol as Dr. Fahad has said, the recovery protocol. And we're running out of them. It's very expensive in our area of the country. So
Equally here also, we are not having Tosi available. So we are using a lot of alternatives. Prashant, you want to say something quickly?
I want to add just one dose is more than enough in most of the patient. Please do not look for the second dose unless you have a very clear indication. So one dose
Kapil,
is more than enough.
Kapil, anything you want to add on that today?
This particular peak, I haven't used it much because most of the patients settle with the initial antiviral and steroids. But my indication will be those who are on the day 10th or day 10th onwards with a clinical deterioration of the respiratory field. That means the oxygen requirement suddenly goes up and IL-6 raised by the threefold what the existing previous baseline available. So, but I just follow strictly the respiratory rate. If suppose my patient is not comfortable, the temporary the oxygen requirement is going up, IL-6 is high, I would like to wait, and most of the time I succeeded in avoiding the tocilizumab. So I'm not very fond of the tocilizumab nowadays in COVID patients.
George, you want to add something? George?
Well, I think so. As everybody say, as well, we are adding to the recovery protocol.
Okay. Pradeep, last question, because and a very $1 million question. Because all the category which we discussed, moderate, moderately severe, severe will be discussed later. Most of the people will write some antibiotic. So what is your one word? When you only need to give antibiotic, otherwise most of the time you don't need to give. Will the patient will you have to give antibiotic?
So I never give antibiotics at all, Rajesh, unless there is a standard reasons in ICU where we initiate antibiotics, where there is an evidence of a VAP or where there is an evidence of bloodstream infection or where there is evidence of a urine or some other secondary intercurrent infection. I don't use antibiotics.
Prophylaxis?
No, absolutely not.
Okay. Dr. Dhruv, we have final comment and then we close.
Thank you, Rajesh. I think first thing on the steroids, we are using little different criteria at Rohtak, and we have already IRB has approved it now, and we are going to our ethics committee. We are using most of the people who are coming with significant hypoxemia. First 2 days, 2 to 3 days, we are trying to use now up to 250 milligram methylprednisolone pulse, and then we go with the national protocol after that. And with this use of our protocol, which has now been approved by our institutional research board, that we are following it at Rohtak and trying to prove it up that 6 milligram, though is good, may not be actually the only answer. So that is what we have found, and it has reduced our use of Tosi. Secondly, as far as the Tosi is concerned, we have got it as a part of multicentric trial, got it published now in Lancet Respiratory, where in our Indian study, we did not find too much of a difference. But there are a few places we definitely are using it. As Prof. Farhad has said it, if you are giving us steroids, a relatively high dose as we are talking about, fever persists, inflammation is there, and CRP is jumping. We have stopped giving any importance to interleukin-6 because of the pre-analytical analytical errors which are taking place in these cases. So we are looking because the basic pathophysiological mechanism for CRP and IL-6 is the same. So we follow it up with the CRP. If it is jumping or galloping, then probably we are not going beyond 400 milligram. On the average we are using is 4 to 6 milligram per kilogram with the maximum 401. We are not at all following the criteria of recovery remap. But at the same time, our use of Tosi, which we were using last year, practically has reduced by 1/10. Fortunately, I have availability of Tosi because last year we had a reasonable number of it, so we continue to use it.
Okay, sir. Thank you. So with this, we end our second series in this webinar where we wanted to address moderate and moderately severe patients. What is the most important thing is that mild, moderate, and asymptomatic patient at high risk need a close monitoring of oxygen, particularly the oxygen level with all its phases, with consultation of some team with some red flag sign where you have drop in oxygen, or like 6-minute walk test become very important for you if you are at risk. If after 6-minute walk test, if saturation drop in any setting, at least by 2 or 3%, you need to be careful in those kind of patients. Close monitoring. We are very careful nowadays to conserve oxygen, reserve and save oxygen. So cutoff for starting oxygen has been, at least should be 92. Some of the center 94 you can take. but at least not somebody having 96 to give oxygen. So wait, yeah, if somebody with 96 is becoming tachypnic, you can give oxygen, but try to find out the reason for it. A lot of people rushes to us with CT scan that COVID positive scored value is 12, 13, 20. It doesn't make any sense or doesn't carry any meaning to me as long as my patient is asymptomatic and not hypoxemic. If patient is hypoxemic, scored value of 5 also has value. And if patient is not hypoxemic, not symptomatic, even 20 value also doesn't carry any meaning to me. So what patient is important, not the CT or MRI value is important. Always remember, the baseline remains why we are insisting that we have to prevent the complication.
रुक जाओ 2 मिनट रुक जाओ.
Baseline, we have to prevent the complication, and for preventing complication, we have to intervene early. And early intervention can only be done when we pick up when patient start deteriorating, because we know that steroid has to be given at a very specific time. Remdesivir has to be given very specific time, and even TOSI, the window of giving TOSI is very, very narrow and very specific. Use after that, it harms your patient. Use before that, it harms your patient. Same applies for steroid. Now, gradually we are able to understand that there are certain patients where remdesivir doesn't work. Severe patient, definitely we do not want to use it. Mild to moderate, they don't need it. So moderately severe patient who start becoming symptomatic, who start needing oxygen where you need to steroid. So if we narrow down our window for the use of these potentially life-saving drugs, that is oxygen, steroid, and remdesivir, probably we can save more patients, and simultaneously, just assurance take a lot of energy, a lot of time, a lot of efforts, because people are so panicked, so apprehensive. And to add to that, this WhatsApp university and media is fueling the thing rather than calming the thing. Everybody is trying to do, despite knowing and understanding anything there. And the most difficult thing is the medical community who is not ready to understand that this is tough time. They have a very narrow window to work. Most of the patient can be reassured. If you just reassured, it take away. At least I tell you that every day, we just by talking, at least 50 to 100 patients, we're just talking every day. A lot of patients just get reassured, their situation improved, they are calm, they don't even need, except paracetamol, they don't need anything. So just start trusting some science, practice science, rather than just starting everything, bombarding patient with doxy, AZ, Flavi, all these things should be stopped. We are not vitamin C, vitamin D3, zinc, cough syrup. And there can be symptomatic treatment. Maximum, your patient needs good dose of paracetamol, that is 1 gram 6 hourly or 654 hourly. Good dose of anti-tussive, because cough is sometimes intractable. Apart from that, good hydration at home and just close monitoring of oxygen and temperature. Patient doesn't need any other things. This is what we have to talk about, the mild, moderate, and moderately severe. I think on Friday, Dr. Arindam will moderate a case discussion on severe case, and then Sunday, Dr. Deepak is going to talk about the critically ill patient. Apart from that, we intend to plan. I have already discussed with Dr. Deepak, and I messaged him that we have to plan one session on resource utilization, and post-COVID care is also very important, because a lot of patients now landing up with particularly those patients who are having severe lung injury, their COVID is becoming negative, but they persist to need oxygen for a very long time, and they are landing up in post-COVID care. So those are the things where we also need to address. With that, Dr. Deepak, over to you, sir. Thank you for the time.
Thank you very much
Thank
to
you.
all the panelists. I would like to especially thank all the panelists, Dr. Dhruv Chaudhary, Dr. Kapadia, Dr. Prashant Nasal, Dr. Kapil Zirpe, Dr. Subhal Dikshit, Dr. Sandeep Rangappa, Dr. Gloria, Dr. George, and Dr. Rajesh Mishra. Finally, it was a beautiful discussion. Everybody enjoyed it. Even I enjoyed it, and I learned many things out of it. And thank you again. And I would like to thank all the delegates, all the attendees who spared their time and joined here and had a lovely discussion on the chat and question answers as well. I know we missed out some chat questions and question answers. We could not answer them, but believe me, the intent was there to answer every question. So with this, I would like to invite you again on the Friday evening. Thank you very much.